Okay, good morning and good afternoon, everyone. Thank you for joining us on this webinar, Economic and Health Needs of Survivors of Human Trafficking. Um, this is a webinar that will be uh, providing Spanish and ASL interpretation, and I will hand off this presentation to our interpreters to give instructions on how to do that.
Thank you. And welcome everyone. My name is Sandra and I am with my co-interpreter Andrea. We will be the Spanish interpreters for the day. And as it was mentioned, we will also have ASL interpretation with Catherine and Lisa. We're going to give some instructions to access the interpretation on Zoom, and we will do this in English and Spanish so that everyone can access the language of their preference. Buenos días, mi nombre es Sandra, estoy con mi cointérprete Andrea. Vamos a ser las intérpretes de español del día de hoy. También habrá interpretación en lengua de señas estadounidense a cargo de Catherine y Lisa. Y bueno, vamos a dar algunas instrucciones para acceder a la interpretación en Zoom para que cada quien tenga acceso al lenguaje de su preferencia. Lo vamos a hacer en inglés y en español. So if you're joining from a computer, please go to the bottom of your screen. You will find a globe icon that says interpretation. If it's not there, you can go to the three-dotted menu that says more, and you will find the language interpretation option. Please choose English, and with this, the feature will be activated. Make sure to not mute original audio or you won't be able to hear the main room. Entonces, si están uniéndose desde una computadora, pueden ir al centro inferior de su pantalla, encontrarán un icono de globo terráqueo que dice interpretación. Si no está ahí, está en el menú de 3 puntos que dice more o más. Hagan clic en la opción interpretación de idiomas. Elijan español y con esto la función estará activa. Si desean solamente escuchar la voz de las intérpretes, pueden silenciar el audio original y así de otra manera escucharán el audio original en un nivel menos elevado y la voz de las intérpretes resaltada. If you're joining from a mobile device, you can tap lightly on your screen and you will have to slide the menu to the right to find the three-dotted menu that says more. Go to the language interpretation option and then press English and press done to activate the feature. Once again, please do not mute original audio. Si están en un dispositivo móvil, por favor hagan clic ligeramente en su pantalla, encontrarán el menú de 3 puntos que dice más. Tal vez tengan que deslizar el menú hacia la derecha para encontrarlo. Vayan a la opción interpretación de idiomas, elijan español y presionen activar. Una vez más, si solo desean escuchar la voz de las intérpretes, pueden hacer clic en silenciar audio original. If you're joining from a Chromebook computer or a phone call, you won't have access to this feature. Si están uniéndose desde una llamada o desde un dispositivo Chromebook, no van a tener acceso a esta característica. Please, if you have any questions or trouble accessing the feature, leave a message in the chat and we will be happy to assist. Si tienen algún problema accediendo a la característica, déjennos un mensaje en el chat y nos dará gusto apoyarles. With this, we'll go back to our hosts. Thank you.
Thanks, Sandra. And before I introduce the faculty, I just want to bring attention to the fact that it is Human Trafficking Prevention Month. January was first declared the National Human Trafficking Prevention Month in 2010 through a presidential proclamation under President Obama. And it was meant to raise awareness of the issue of human trafficking and also encourage organizations and government bodies to take action against it. And one way you can do so is through using the Office on Trafficking in Persons toolkit. Every year they release a toolkit, although it is the end of January, a toolkit with different focuses on the different weeks of January. But even though January is coming to a close, the toolkit is still chock full of valuable resources and instructions for education and building connections that can help prevent human trafficking in your organization. So with that being said, good morning once again, or good afternoon. My name is Jake Sessa. I use he, him pronouns, and I'm joined with my colleagues Anna Maryavi, and we work on the Futures Without Violence NTAP project, Health Partners on IPV and Exploitation. We're also joined by Caroline Oia and our featured speakers, Dr. Kimberly Chang and Dr. Amy Young. Next slide, please. And just a little bit about our program. We are part of the Futures Without Violence led and HRSA BIPIC funded NTAP program that provides technical assistance to health centers. We do so through communities of practice that go in depth onto key topics for small cohorts and multi-session trainings. We also do live webinars such as these and have an archive of these live webinars on our website. And we also create tools and resources, including those for electronic health records. And a lot of our tools focus on the evidence-based approach, uh, including the cues intervention. And you can see more of what we do on our website, linked below. Next slide, please. And I'll give Caroline an opportunity to intro her work.
Hello, everyone. Thank you so much for being here. My name is Caroline Auya, and I am at Futures Without Violence, a program manager on the Workplace and Economic Opportunity team. Our team is dedicated to ensuring that women, families, and all people can have the economic choice that they need. They can have dignified employment and freedom from violence. We do this through three key initiatives. We run a national resource center called Workplaces Responds that offers free training to employers and workplaces on how to address the workplace impacts of domestic violence, sexual assault, stalking, and sexual harassment, along with exploitation, because we know that violence is very interconnected. We also run a project focused on building awareness around the employment rights that survivors have as a result of the impacts of the violence they're experiencing. And then we have a Pathways to Opportunity initiative that seeks to build regional collaboratives that create trauma-informed career pathways for survivors of domestic violence, sexual assault, and trafficking as well. So we're excited to be here to talk about the intersection of all of these things. Next slide.
All right, just to go over the agenda, we will start off with some level setting and definitions, including human trafficking and exploitation dynamics and the health impacts that they may have, and an introduction of Loma Linda Rica. And we will go into a discussion on human trafficking and exploitation prevention and some of the precursors to employment and economic stability. And then we will go over a second discussion on the specific needs of human trafficking and exploitation survivors and some strategies for survivor employment support. Next slide, please. And these are the learning objectives. At the end of this webinar, attendees will be able to describe the economic and employment needs of human trafficking survivors and their connection to safety and security. And they will be able to identify two strategies that HCs can implement to create employment pathways and also to define the mental health needs of HT survivors and how health centers and their partners can address them. And I will now pass it to Dr. Chang.
Good morning, good afternoon, everyone. I'm Dr. Kimberly Chang. As you heard, I'm a family physician at Asian Health Services here in Oakland, California, a community health center serving everyone without regard to their ability to pay or insurance status or language, ability to speak English. I just wanted to reiterate that what we want to implore to you today and to show you today is that exploitation and human trafficking are issues for the community health centers and healthcare sectors, that the medical, emotional, physical, and psychological abuses and harms lead to impairments in employment and economic harms for victims and survivors, and that we in the health sector and our health system can help patients not only with their healthcare, but also with employment skills, And we hope that you can model what you hear about today from Dr. Young, and that this will inspire you and your organization to think broadly about the needs of your patients and clients. So let me start with a patient story. I had a patient who came in who was pregnant, had a lot of morning sickness, couldn't work because of dehydration and dizziness. I wrote her a note for her work employment stating this. She comes back the next week and says that her employer is very angry, that if she can't work, she's going to be fired. Knowing a little bit about employment law, I said, well, wait a second, you're pregnant, you're sick. This is not appropriate. And so I wrote her another note for her employer that, she couldn't work, and this was allowed under employment law. She comes back the next week and is very distraught, crying. And next slide, please. Next click. She tells me that her employer, next click, please. Next click. Her employer is going to fire her husband, her brother-in-law, and all the employees from her community at the restaurant. And so, is this human trafficking? Is this exploitation? What can I do as a physician to be involved in this? Well, let me tell you, I want to just emphasize, next slide, please, that understanding human trafficking and exploitation from a healthcare sector is really very similar to understanding intimate partner violence and the dynamics of power and control. The difference is that in human trafficking and exploitation, there is a profit motive. And so you can see in this patient's case that she was undergoing some employment exploitation, and there was a profit motive. There was exertions of power and control and threats on the patient and her community. So we did get her involved with some community-based organizations and help and advocates. And down the line, this particular restaurant group and employer got fined for several wage and labor violations. Next slide, please. So when we talk about exploitation and human trafficking, I want to emphasize for us in healthcare that it's not that we are investigators. We're not criminal justice investigators looking for labor trafficking, which is labor or services induced through force, fraud, or coercion for the purposes of slavery, peonage, debt bondage, or involuntary servitude. We're looking at the broader spectrum of labor exploitation, where an employer unfairly benefits from an employee's work. It's not a legal term. In fact, not all forms of labor exploitation are illegal. We're also looking at labor violations and understanding how they can impact the patient's health. And these labor violations are a legal term used when employers violate federal, state, municipal laws related to worker treatment, workplace safety, or record-keeping requirements. Next slide, please. Similar to the labor exploitation and labor trafficking is sex trafficking. Severe forms of sex trafficking in the criminal justice federal legislation are commercial sex acts through force, fraud, or coercion for the purposes of involuntary servitude, slavery, debt bondage, peonage. It is also a commercial sex act for somebody under the age of 18, for which force, fraud, and coercion is not needed. But again, in healthcare, we are not criminal justice investigators. We may not know the whole dynamics of a patient's situation, but we can see that there's an overlap with the broader rubric of sexual violence and then sexual exploitation, which is the attempted abuse of a position of vulnerability, power, or trust for sexual purposes. So for us in healthcare, we really want you to understand that we're looking at the broader spectrum of experiences and really looking to help our clients and our patients. Next slide, please. This is a healthcare issue. Some studies have shown that of trafficked victims, almost 88% of them had encountered a healthcare provider or visited a clinic while they were being trafficked. And during that time of their trafficking situation, they weren't identified as being trafficked. So this is an issue for us. Another study showing the kinds of providers that patients or victims will come or survivors will come into contact with. And you can see it's a whole host of providers that are out in the community: dentists, urgent care, emergency, OBGYNs, primary care providers, pediatricians. alternative healers. And so this is an issue for us. Next slide, please. I want to really emphasize the point that people who are exploited and trafficked have healthcare issues and healthcare problems that they need to be seen for. These are some examples: gynecologic issues, infections, prenatal care issues, emergent injuries. Remember the dynamics of power and control through physical violence, physical abuse, emotional abuse. Next slide, please. There's also mental health issues from the abuse, violence, and trauma that occurs. And so you can understand that if a patient or a person is abused by their employer in many ways, that they may have problems relating to future employers. They may have medical conditions as well that affect their ability to maintain their jobs. Next slide, please. And these kinds of mental health and psychological issues can affect their performance in the workplace and their employment opportunities. Next slide, please. There is the intersection of health and economic security. And I want to emphasize, when I see patients who have come out of these situations of violence, trauma, and abuse through trafficking or intimate partner violence, that their injuries often lead to their needing to have several visits outside for counseling, for other specialists in medical care. And this impacts their ability to maintain continuous work. They may have gaps in their work history or their education. They struggle to meet basic needs. They haven't adapted to necessarily a workplace culture that is healthy. And so these kinds of issues can present challenges for their economic security. Next slide, please. What we want to move into now is to explore how health systems and the work or our organizations can prevent and intervene in exploitation and help our patients with the economic needs that they may have, in addition to the health needs. The health needs and medical needs we know how to do. The economic needs may be something that we are just starting to learn about. Next slide, please. For us in health centers, I want to just give you level set and let you know that health centers are in every single community, state, District of Columbia, and territory of the United States. There are 1,500 community health center organizations with over 15,000 sites, clinical sites across the United States territories and District of Columbia. We have pharmacy, mental health services, substance abuse programs, dentists and oral health services, and many of them do also provide different pathways to economic stability. We're required to see medically underserved areas and medically underserved populations. You can find a health center there at that link there in your community to find out what may be close to you and who you can work with. So I wanted to just level set that to say that there are primary care organizations out there. And now we're going to move into a presentation from Dr. Amy Young, who's going to talk about her initiatives at her organization to develop economic security for patients who have been trafficked and exploited. Thank you.
Thank you, Dr. Chang. So my name is Dr. Amy Young. I use she, her pronouns. We're going to move kind of quickly through some slides just to give you an overview of the program, and then we'll get to conversation, which I think is more engaging and gets to the real issues. So we can go to this is Loma Linda University. I am the founder of a program called the Resiliency Institute for Childhood Adversity. My training is actually in pediatric medicine. I'm board certified in pediatrics and also in a subspecialty we call forensic pediatrics or child abuse pediatrics. So I'm a subspecialist in child maltreatment cases. And I've worked for 20 years in this field and sadly have found there are so many roots of exploitation and trafficking that begin in early childhood with childhood victims. We could go to the next slide now, and I'll explain a little bit about forensic medicine. So our expertise is in the biomechanics and mechanism of injury. We diagnose, we treat and evaluate and diagnose thousands of children every year. I'm located in San Bernardino County, which is a pretty large county. We have very high rates of child abuse with only one level 1 trauma center. So Loma Linda Children's Hospital serves the entire Inland Empire and a geographic area that's larger than 9 states in the country. The cases that I'm involved in are suspected cases of child maltreatment. That can be everything from severe physical abuse, head trauma, organ injury, cutaneous injury, burns, fractures. But a large percentage of what we do is also child sexual abuse, and most sexual abuse and sexual violence against children involves themes of exploitation. And many of the children that we are caring for who are trafficking victims that are even slightly older were victims of abuse when they were very young and didn't get all of the services and wraparound support that they needed. Sadly, as a subspecialty, we are the smallest in pediatrics. So there are about 55,000 pediatricians in the country, about 1,500 hematologists and oncologists, to give you reference, and less than 350 child abuse physicians that are practicing. You can imagine the reasons for that. Subspecialty in general is difficult to recruit physicians to. It's more training. But this area does bring a lot of burnout. And part of that is because historically forensic pediatricians come in on a case, evaluate the case, either inpatient or outpatient, depending on the severity of injuries, give an opinion, and then there's just more and more cases coming, and you do not necessarily follow those children, which is something that we set out to change with the initiation of the Resiliency Institute, and we'll talk a little bit about that. We can move to the next slide. So I already talked about the geographic area that we're in San Bernardino County. We have about 4,000 cases of severe child abuse in a year that we investigate, and about 25 homicides. Among our cases, I would say we're at about 50% that are that the primary incident is a sexual abuse case, 50% for physical abuse. But as you would expect, many children who've experienced one form of abuse have experienced other types as well. You can move forward. This is our Children's Advocacy Center in San Bernardino County. It's about a 13,000 square foot facility. This is a true collaborative between multiple county agencies and Loma Linda University Children's Hospital. I'm the medical director of the clinic, and the medical providers are the lead agency at the facility. That's important because investigators often have different needs for criminal, civil, juvenile proceedings, but we want to keep the child's needs as the center of what we are delivering. And so this is a very child-focused atmosphere in which children are kept center, and we conduct an investigation there. We can advance the next slide. We offer a multitude of services. This is a nationally recognized center of excellence. So hopefully in the counties you're in, you have a children's assessment center that you can refer to that brings everything under one roof. We want minimal facts interviewing done in the field, and then we want to be able to bring young victims, and this can be up to 21 and even beyond, to have forensic interviews, a medical exam, advocacy services, and mental health in one location. Typically, these facilities are not set up to follow children long term. And what we see that develops is gaps in ongoing medical care, mental health, and even their safety, because as the system leaves, children can enter back, young adults can enter back into dangerous situations where abuse continues. And so our advocacy center has now expanded to a Resiliency Institute, and we'll talk about that in a couple slides. We can advance. Within our facility, we do partner with the Department of Behavioral Health, Children and Family Services, our district attorney's office, every major law enforcement agency, and the sheriff's department, as well as local nonprofits who assist with funding. We can advance to the next slide. So with, the study of adverse childhood experiences in the 90s, what we really as medical providers has begun to pay attention to is that a lot of what I learned in medicine was a band-aid on a problem, right? If a person has hypertension, a pill, high blood sugar, a medication. But are we really spending the time understanding what people are experiencing in their life and what has happened to them? Dr. Chang gave a really good example of a physician who had to dig deeper to find out what the root of the problems really were for this young woman. And that is something that I find as a constant theme in child abuse, where children disclose late, and when I ask why they haven't told someone, they say, nobody asked me. But it's not just child abuse that is a significant theme of adversity in childhood. So there are, Dr. Folletti at the Kaiser Health System, and you should read this study, you probably all have, looked at a multitude of adversity. It isn't, it doesn't cover all the types of adversity, but what we know is that as more adverse experiences add up in your young adult life, then this can lead to long-term bad health outcomes. So really, if we want to look at what the number one public threat is in our country, it's really getting to the root of adversity, and which are the themes that we're discussing today that happen in early life. We can advance. So this is our Childhood Resiliency Institute. So the vision here, and I had numerous cases that I was involved in where examples of a small child, a 3-month-old little baby who came to me with multiple fractures. The mother was the perpetrator of the abuse. The system did everything that it needed to do. There was a protective order. Father was able to get the children placed back with him eventually. I testified in court. Mother was sentenced. But as the system fell away, the father let the mother back into the home. And fast forward 3 years later, this child was a victim of ongoing sexual abuse and physical abuse and died at the age of 3. I also had a growing number of children who were victims of child sexual abuse, trafficking, and didn't have anybody to support and nurture and follow them as they aged out of foster care group homes, juvenile court systems, to follow them and look at economic stability and education as a way to break the cycles for them. So the Resiliency Institute was to bring everything under one roof. A child's investigating all of the forensic services, but then also the ongoing primary medical care with subspecialists also embedded in the clinic, and then a teaming approach with mental health providers, and then our educational advocacy program, which I think has brought a considerable benefit to children. We could advance slide. So these are just some pictures to show you it's nature themed, as that is a resiliency factor, as a connection to nature. There's some research published on that. If you're interested, I can provide a link. Every room is after a national park. It appeals to all ages. Adults often tell us, I wish I could come here for my medical care. We can advance slide. Our mental health spaces are very warm and inviting. We have many modalities of trauma-informed care that we deliver in this facility. The key point is that everybody is at the table for the care of this young person. A medical provider, a mental health provider, a community healthcare worker, an advocate, as well as a coach for educational and post-secondary planning. We can advance slide. And that is our program, Give Back. This was a program we launched in 2017. It is a national nonprofit that provides scholarship and support to young people, particularly a focus on children who've experienced foster care, homelessness, or the incarceration of a parent. Every young person that comes into our clinic, 9th grade and older, who shows an interest in making a post-secondary plan, we attach a coach to them, and that person follows them all the way to college or career completion, even to career placement. We can advance slide. And we have now begun to hire young adults from our program who have completed their degrees or certifications as medical assistants, community healthcare workers, and coaches in our program. And this really breaks down the stigma for young people and gives that kind of entry into the program where they're meeting with someone who has been through similar circumstances and can help create that vulnerability and trust that's needed to lead to healing so that young people will lean in. And on that, I think we will move to our discussion.
Great. Hey, thank you, Dr. Young, for everything that you do. We're going to talk a little bit. We just wanted to have a discussion about your program. It's very inspiring. And you mentioned earlier that there's only 350 of you, less than 350 forensic pediatricians in your type of child advocacy centers across the country, I think. Is that
Yes.
right? Yeah.
Yes. Yeah.
So how can we in community health centers, in federally qualified health centers, and in primary care, work with your type of programs and scale these resiliency programs and economic opportunities and trainings to communities across the country who may not be blessed to have a forensic trained pediatrician like yourself in our midst?
Yeah, I think there are a couple things. I think we need primary healthcare champions for young people. Because forensic medicine is so small, it is difficult to get to specialists. We actually got our start in a federally qualified health clinic nearby. So we had the great fortune of starting our program in collaboration with SAC Healthcare System. And so we were really plugged into medical, dental. That meant that my young victims, their parents could see a healthcare provider, and behavioral health was on site and dental was on site. We just grew big and needed to move into a different location, but we still partner with our FQ. And what that means is those clinics can reach out to me. They know where to find us, to run cases by us, to figure out how we can best collaborate together. And then what we've done in our healthcare facility is to recruit, in my program, is to recruit primary healthcare providers who want to get training with us to recognize the signs and symptoms. This is really our duty as physicians, right? When we're treating young people, we need to know how to identify and how to appropriately report. It doesn't always take a specialist. And so we're beginning to bring in what we call our trauma-informed primary care providers, who we train, that are in family medicine and pediatrics, to create like a consortium of physicians who work together. And that's where I've really found you can get more consistent champions who will follow people long term. And there's never a physician who tells me, well, I don't want to incorporate mental health and a CHW and a dental, everybody wants the biggest team we can get together to support people. And the best place to do that, I think, is in the primary healthcare clinics you're talking about.
Great, wonderful. That's really heartening to hear that you partnered at the local level and started at community health center. So I love that you're training local primary care providers, and you have this vision where you can hopefully scale this nationwide. How do you think that you can do that with your, are you working on the community advocacy center side as well, trying to inspire your folks to work with community health centers? And then on our side, we need to do the work to get community health centers to work with you.
Yes, I think it all starts with relationships, right? I think it's just having a very firm spirit of collaboration. And, I think we've seen a lot of benefit to creating a collaborative board that brings everybody to the table from the various organizations, so that we each bring our own strengths. And we have intentionally designed that so that leaders of the community sit on that board. So our chief executive office of our county sits on that board, the elected district attorney, the sheriff's department, our elected sheriff, but then we have nonprofits and community healthcare providers who join. And that's when we really come up with innovative entrepreneurial ideas for patients.
That's great. I was also going to ask you, this is just a little off script, it's more
That's
of
okay.
So you mentioned you have community-based folks. What can the advocates and the survivors themselves do to catalyze this participation and this partnership amongst the different specialties, the community health centers, and other groups? Is there a way to do that?
Yeah, I think that we need to be intentional about centering youth voice, victim voice. We have a young woman who, there are many things that existed to help her, but it was a victim of human trafficking, but everywhere we called, it wasn't working. It wasn't responsive. It was a weekend. The staffing was low. The doors had closed for funding, and you run into that and it can be very exhausting and you give up, right? A young person gives up. You call the helpline and it's triggering. They use wording that I don't think you're ready yet for help. Are you really ready? And now the person yeah. So you have to have someone to walk that journey with them, but then they need to be able to have the voice to go to the community leaders to say, the 211 that you gave me didn't help. These hotlines that you gave me, they're not working. Here's what I ran into. Here's how it felt to try to access those services. And here's why it didn't push me along on the next step. The key for her was that we stayed with her every step. And I think that, and I know we're going to talk about this more later, but our focus was really the economic, job, and housing. And then we could access all the other care when she was ready.
That's a great approach. So let me ask you this. How do you think navigating through the non-clinical factors of health, as you just mentioned, the employment, getting her employed and economically stable, how do you think navigating through that factor, that sometimes, I'm a doctor, you're a doctor, it feels out, we weren't trained this way. It feels outside of our health system's locus of control, housing, job, job readiness, education. It's outside of our sphere of control. How do you navigate that? How do you think about approaching that? I mean, you've done it. So walk us through.
Yeah, I think I look at it as if we don't help people with the essential basic needs, we're not going to make progress in any of the other areas, right? Even in their healthcare. And so much of what I've done has been informed in the trenches. It's like, I want to help this young person heal, but they're telling me, I have a dental issue. I can't, my vision is, I don't have stable housing. I don't have food. So it's like, I can give them all sorts of things. I can even say, go meet with a mental health professional. But if I don't find ways to meet the basic needs, they're not going to be open or really able to heal. And so I think it's a big job. It's not easy. And it's also not that difficult is what I've learned. If you take the time to make the relationships and bring in the partners that know what they're doing and make the connections and learn about what's available in the community and really build a team that sees it the same way as you and wants to walk the journey with someone, it works. And it doesn't have to be for thousands. It could start with 10 and 20 and 100, and it will transform their lives and our lives as healers.
That's great. In many ways, I see what you're doing as creating new systems, right? You're not following necessarily what you're told to do. You're saying, hey, it's not working in this sphere of control or this sphere of control, and you're building them together and you're building a new system. That's great. Thank you for what you do. I want to ask you a hard question. How do you fund the services that you provide?
Yeah, so, the way we started was grant writing. Like tons and tons of grant writing. And you will find that for things like this, you can be pretty successful with powerful stories. And so, like you said, Dr. Chang, this system I was in wasn't working. 10-minute, 15-minute visit driven by healthcare, reimbursement, that wasn't working. So I started by writing grants, and every mental health provider and community healthcare worker and advocate I brought on was grant funded. And then it started to feel like, well, what if those grants go away? There has to be a different way to do this. And so that's when we started advocating with our health plan. We work with Inland Empire Health Plan, just very like-minded people who are like, how can we help you think outside of the box? Maybe a case rate development for your medical visits. Are you open to implementing enhanced care management? That could help stabilize your healthcare workers and advocates. And so it's more of that, like, I can call them and team with them, and that has brought a big difference. And then I also would say advocating at the state level for models like this. So testified to the Senate and Assembly to tell them, like, these are the systems we need that are beyond what is currently supported and funded. And then we were able to bring in state support for what we've done. So it's being an entrepreneur. which I don't think we think of ourselves as physicians, but if you really, or healthcare providers or mental health providers, if you read entrepreneurial spirit, like that is really what you want to do, because it creates the new inventive systems that really change people's lives.
That's great. Thank you so much for sharing that. And I'm also struck by your approaching working with your health plan, because as you know, primary care gets 5 cents on the dollar, right? And you're doing a lot of primary care services, on the ground services, and advocating for that, a little bit of a reallocation of the healthcare dollar to fund these non-clinical factors of health is really going to make an impact for the patients that you see. One last question before we turn it over to Carolyn and her conversation with you. How do you maintain your hopefulness that you can make a difference?
I think it really starts with the small victories. If I stand at the graduation of a young person and they say, "Man, Dr. Young, if you weren't there for me, I don't think I would have made it." You just, once you know it, it's like you can't shut the door to it, and all those small victories add up. And when I see them get their first house or their driver's license, or we help them get a car through a grant or a donation, and then I lately have seen they want to work with us now, and they want to dedicate their life. And it's like, okay, that's carrying the torch. Like, it's hard to lose hope when you have a lot of people around you. And then I didn't mention this either, but our county leaders have stepped up. And in medicine, we can often think we're in a silo, right? I mean, there were many years, Dr. Chang, where I didn't know anybody at the health plan, even though we almost entirely saw patients from that health plan. But as you broaden your relationships, and this includes the county, we've gotten direct support from the county, because there are many people charged with doing the same thing we're doing, but everybody's doing it in silos. And if it's together, it just becomes bigger and better. And then it's hard to lose hope when you're with a team of people who see things the same way that you do and want to see significant change.
That's wonderful. Thank you for reminding us that the victories that we notice count. So I read something the other day about all the good in your life depends on your ability to see them. So thanks for reminding us to keep an eye out for all the victories, whether they're small or very big, and to notice them. I'm going to turn it over now to Carolyn Oyuga, and she's going to carry on about economic issues. Thanks.
Thank you so much, Dr. Chang and Dr. Amy, on really doing a great job of weaving the intersection between health and economic security. If we can get the slides back up, that would be great. And what we're going to do is we're going to zoom out a bit to understand what survivors of trafficking across the nation are reporting as their needs at exit of exploitation. So when they are trying to transition from that space of being exploited to receiving security. And so we'll wait for the slides to come back up. And I am putting in the chat box a study by Polaris called "In Harm's Way: How Systems Fail Human Trafficking Survivors." And this 2023 study interviewed about 400 survivors and found that 75% of survivors who participated in that survey said that they needed help with accessing behavioral or mental health services. 65% mentioned that they needed help accessing quality trauma-informed medical services. 69% mentioned that they need help getting a job, a living wage job. And so those were some of the three major, needs that survivors across the nation were saying they needed in order to feel safe. And then we also heard that 60% needed help with getting an education or job training. So with those four things being a major need, it's been interesting to hear from you, Dr. Amy, how you're weaving all of those things into one particular clinic. And what's also interesting is that the study found that the top needs beyond, exit of exploitation. So we're saying years down the line after they've received medical care from you all, is 39% needed help, still needed help accessing behavioral mental health services. They needed help getting medical services that were trauma informed and could really manage the chronic or long lasting health issues that they were experiencing. And these needs are provided by healthcare systems. And it's critical, as Dr. Chang and Dr. Amy mentioned, to a survivor's ability to maintain and obtain education and employment. So I want to share with you a story, and we'll go to the next slide. I worked with a survivor in Northern California who had been labor trafficked in the restaurant industry. They had significant PTSD, physical ailments from the long hours and the harassment and the abuse that they were experiencing within that space because it was an incredibly toxic work environment. And while they had skills and experience in the restaurant industry, they couldn't step into a kitchen without panic attacks. They couldn't stand or use their hands without deep pain. And they were struggling to gain enough income to keep a roof over their head. This survivor would tell me that they barely left their home except to go to their medical visits. And it was at these visits that they felt the most comfortable disclosing their pain, disclosing their desire to one day work again, feel valuable, and take care of themselves financially. And it was at these doctor's appointments that they would ask often, when you all say at the end, how can I help you? They say, well, can you help me with this process of getting an opportunity that will help me feel valuable, help me keep the roof over my head again. And so this example highlights that health and economic security are not separate issues. They happen, they co-occur, and they often must be addressed that way. And a note from you helps that survivor get disability insurance. So that medical provider was able to help that survivor get disability insurance as a result of what they were going through. Your evaluation and care supports them in getting workplace accommodations in a safer environment so that they can still continue to work, but deal with, some of the pain and ailments and get support for what they need in the workplace. Your strong and warm referral system makes sure that survivors get the psychiatry and mental health services they need to exist safely in their body and their mind. So I just need you all to know from this study and these stories that as a healthcare provider and system, you are a critical part of the equation for helping a survivor meet their economic and employment needs. So let's dig deeper into what those employment needs are. We're seeing on the screen here that about 73% of survivors mentioned that they need help with getting a stable living wage job. So not a job, any job, right? A lot of survivors are making less than $25,000, to take care of themselves annually. We heard that 74% of them need help with getting a job that's a good fit. So it's like, I want to feel valuable. I want to support my community. I feel, passionate, right? About certain things, but I don't know how to get there. I've never seen it before. 65% are asking help for getting education or job training or skills training. And then some are asking for learning basic life skills that will help them be successful in maybe articulating to you what their needs are on a regular basis, right? Having that confidence within themselves to ask for what they need in different settings. Now, I know some of you are looking at this slide right now and you're like, I'm a healthcare provider. Why does this matter for me, right? Getting a job, that's not my responsibility. This is too much. Well, the first thing that I'm going to say is that we all have a shared responsibility for supporting a survivor in their overall health and well-being. But especially right now, under the big, beautiful bill, starting no later than January 1st, 2027, a lot of the safety nets that survivors rely on to receive medical care from you all are going to require that survivors are and individuals in your community are engaged in 80 hours of community engagement. And the way that they define community engagement is that they are connected and participating in some sort of education or workforce opportunity. And so an example of this is starting in 2027, Medicaid expansion adults are going to be required to do these 80 hours of community engagement. And it's going to be up to you all and the states to verify that an individual is participating in those things at the application for these benefits and 6 months after to be able to keep them. So it's showing that your relationship with employment pathways and career pathways and education pathways is going to be even more critical than ever in order for survivors to maintain the safety nets that they need to continue receiving services. And so some examples of what those things are, educational programs, it can look like receiving an income of a certain amount, and we will send you more information on these new requirements to help you all think through how you're designing your programs and your referral systems. But it's important that if you all are in a healthcare setting right now and you do not have a coordinated plan or relationship with a workforce job training or education institution, it's critical to either start developing those relationships so that you will be able to support survivors in these changes. Next slide. So similar to social determinants of health, there are social determinants of work. And next slide, please. I'm not seeing it on my end, and hopefully you all are seeing it. I know my time. So there are social determinants of work, and these social determinants of work highlight interconnected factors that impact a survivor's ability not to just maintain employment, but other economic opportunities. And the Health and Human Services Office of Disease Prevention and Health Promotion has adopted a Healthy People 2030 framework. And under this framework, HHSA has a vision of a society in which all people can achieve their full potential for health and well-being across the lifespan. And a core principle they have identified for reaching this vision is creating social, physical, and economic environments that strengthen the ability for that survivor or any other patient in your healthcare settings to achieve health and well-being. So what this means is that we can't address this without shared responsibility, without communication and coordination, and without strategic collaboration between healthcare systems, economic safety nets, and then the education and employment pathways that are within our communities. So we're going to go ahead and take the slides down and have a discussion with Dr. Young to dive a little bit deeper about how they're incorporating this piece into the Resiliency Center. So I'll have a moment. Okay, there we are. So Dr. Young, I want to just say that I'm so excited about your model, and I feel like ever since really learning about it, I'm ready to scream at every rooftop, right? To go ahead and create something similar. And so the first question that I have for you is around this idea that you mentioned with Dr. Kim, that everyone is at the table for care. You've mentioned that over and over and over again. And what I have found in healthcare settings is that we might have dental, we might have social worker, we might have a mental clinician that's at the table. But then that workforce employment or education component is that referral over there in the corner, right? Or that organization organization that's across the street. They're not at the table. So I know at your organization, you all have an enhanced care model where that role is really embedded into your services and your care team. And you mentioned something about co-location. So could you talk a little bit about what is the benefit? First of all, what does that level of integration look like? And then what is the benefit of that collaboration to the patients that you're serving?
Yeah, I think what I've learned over and over is exactly what you presented. That I may be setting out to help a young person who's been a victim of commercial sexual exploitation. There may be substance abuse issues, unmet healthcare needs, and what I have found is I make almost no progress if I can't help them with what they care about most, which is consistently when I say, what is it that are your goals? It's almost always safe housing, access to food, and a job. Maybe they need their paperwork back again, or they need a driver's license. And until I can make progress in those things, they're not very necessarily very open to all the other issues because it's just too much of an obstacle, right? And so when we brought in the economic stability or that workforce piece, that actually became the navigator for the patient. So they're assigned this advocate who now helps them manage all of the other areas. Let's get your driver's license. Let's get your papers back in place again. Let's go look at housing options. Let's figure out how we're going to get it paid for. Let's help you apply for your CalFresh, and we have a food pantry. And once they see this person is consistent and reliable and trustworthy, now they're much more open and ready for the other aspects of their health. So we call it social determinants of health, or social determinants of learning, or social determinants of work. It's the basic needs, and it has to be guided and met the patient where they're at. And then we give them one navigator that's their point person. And then we bring all the professionals to the table to discuss and find out the ways to help most.
Mm-hmm. And how often are you coming to that table? Because sometimes that's the question, right?
Yeah.
In terms of the coordination. So could you talk a little bit about that nuance?
Yeah, it depends on what the patient is coming to us for. So if we have at least case reviews every week. We have big multidisciplinary team meetings twice a month. It just depends on what we're working on. If it's a very small child who's been a victim of abuse, then that is one separate multidisciplinary process. But for our young people where we're really working on the stability and the workforce, that is checking on them every single week, face to face with them every month, out in the community with them at least once a month, accessing resources. The navigator goes to their medical appointments with them, mental health appointments with them at their lead, if that's something that they want. So that piece is our most intensive piece, I would say.
Mm. That makes sense. And I know in one of our conversations you said that or what are some of the challenges, I guess, in a health system collaborating with the community-based agency? So that model sounds great, but we
Yeah.
know that sometimes these are two different systems, two different rules, right? So
Yeah.
what are some of the challenges you're seeing in that level of coordination?
Well, I think some of it is an imbalance between what the healthcare system has available to it versus what the community-based organization has available. So, like, if you look at enhanced care management, we're going to do that on both sides of the house, the nonprofit and the medical side. But the medical side has electronic medical records, billing systems in place, a lot further along than our community, our nonprofit that we're rolling in. But they mutually benefit from each other. And so there's memorandums of understanding that can be put into place. And then what you will find is that you're available for additional funding and resources often when you do apply as a true collaborative like that. So I think in the end, it's a big benefit to both entities, but can be hard to work out the initial logistics.
That makes sense. So it may be painful at first, but it's helpful
Yes.
to be patient along the way of getting it to that level of coordination. Yeah.
Yes. And if you are implementing enhanced care management somewhere and just getting started, it is very painful at first, but it is worth it in the long run.
That makes sense. And I hear that your healthcare clinic partners with schools also to provide a curriculum around career. It's called Life Passport or something like that. Could you share a little bit more about what that curriculum is? Why would a health center do that to begin with?
Yeah.
And what the collaboration with schools is like? Why is that beneficial to your health clinic?
So we have a group of about 200 young people that we have provided scholarships to. We follow those young people very closely in intensive advocacy. And as we were going in that program, we gave them a scholarship to college, right? It paid room, board, tuition, and fees. But it wasn't just money that young people needed. We kind of quickly learned that. These were young people who were aging out of foster care, had been, couch surfing, unaccompanied youth. They needed like the nuts and bolts of that more social emotional learning. So we started to create programming for them that grew grit and mindset and did a pathway for their future in a blueprint and created a passport for their life that involved the careers that they were interested in and inventoried their interests. And then what we found is our young people, they weren't like the national statistics saying that only 10% of young people aging out of foster care will go to college and 3% will finish. We've got in our group, 97% of kids are on track for their post-secondary plan, whether it be a career or a college. And so the schools approached us and said, could you take that curriculum and adjust it and deliver it on a school day in a 50-minute group mentoring session to young people in a club type setting on school campuses. So we go to 60 schools every month, and we have about 25 young people per school site, middle school and high schools, and we deliver this give back curriculum to them. It's 50 minutes. It's a group mentoring session with young people experiencing homelessness, incarceration of a parent, or foster care. And we create this cool club environment that is first founded on community and relationships and values that we share and uphold in our community. And then we expand that to deliver the curriculum and help them develop a path and a plan for their life. And that is what we've seen kids now improve their school attendance, their behavioral issues at school diminish, their hopefulness about their future and school have improved. But really, the curriculum is great and it's free and we'll share it, but you have to create relationships. Young people and people in the situations that we're talking about need like one caring, stable, nurturing adult who will follow them on their journey.
Mm. And so I know some of you in the room, as a part of a community health center, probably have some sort of community health outreach, wing of your health center that focuses on, connecting with others. And so I'm hearing that this curriculum is free and they could access that to help inform the
Yes.
work that they're doing.
Yeah, absolutely. So currently, some of it exists on giveback.ngo. I'll share that website, but we're about to publish more of it. And so I will also give my email in the chat if anybody wants to reach out.
Awesome. And so my next question, and then I know we also want to see what questions the audience may have, for you, is so some of the people in the room may still feel like the strategies you're saying it's hard to replicate within their particular healthcare system. And so what is your advice, right, on some of the core pieces where they can start, like some of the core
Yeah.
pieces that they can go to start replicating some of the strategies you all are doing within a primary care community health center, which may operate a bit differently?
Yeah, I think I would say start with something that's really important to you, something that you feel is a first step you can take that you're passionate about or you have seen is something that, we all need to exist in spaces where we're like, my life makes a difference, especially when I get to do this thing that I know I could help figure out. For me, it was education. I was this forensic doctor. I didn't see kids long term, and they were starting to come back to me because they had a relationship with me. I wasn't their primary care doctor. I didn't have much to offer them, and they were like, Dr. Amy, I just want to go to college and I can't figure it out. And I was like, I can start there. So, okay, I'm going to start a small group of young people that we bring together and we do some post secondary exploration. And that's where I started. And then we were able to offer scholarships as that progressed. And then those young people wanted to stick with us, and I was able to hire them. And then I learned about community healthcare workers. So it just takes a seed and a starting place and something that matters to you. It doesn't work well to go, I'm going to do this program and then go backwards. I think start with a group of people that you are helping and serving. Identify an issue they have and start there, and it will roll out from there. The right thing will happen when you approach it from that way. So I didn't set out to have a primary care, ongoing, trauma informed clinic. I just set out to say, what is the next thing I could do for these young people? And then it developed naturally. I hope that makes sense. I just say,
Yeah.
start with 10 people in some area that you're very interested in. Find someone to connect or partner with. And if it's me, reach out to me and I'll tell you, here's how I did a scholarship program. Here's how I got the CHWs on board. Here's how I did ECM, enhanced care management, and just start somewhere.
Right, right. No, that makes sense. I'm hearing that you really want to tailor it to your community. And I'm seeing in the chat box, Roxanne, thank you for mentioning how this shows up in the agricultural center in your community. So maybe the question becomes, how could we address the economic needs of that particular sector at your health center if that's what you're seeing on a regular basis as a core issue? Right.
Yes,
I hear that.
absolutely. Mhm.
That's awesome. Are there any questions that have come through that we could lift up? Because I know we're getting closer to the end. And so I'm looking at the chat box. And team, I don't see the Q&A hub, so I might miss if you have any that you're seeing that we can.
There is one question, Caroline. This is
Mhm.
Anna. Where does the funding for this program come from? And lack of funding, is a huge challenge, for different communities and different states. And so if you could maybe give some specific examples, both at the sort of local level as well as maybe the state or national level in terms of how you're receiving that funding.
Yeah, I think it's easiest to probably just tell you how painful it was at the beginning. I literally went to a golf tournament and I was a guest speaker and we were the fund a cause and we got $25,000 and I thought we were rich. And I was like, okay, that wasn't so hard to do. And so we started to look at philanthropic places where we could fundraise and even just do our own fundraiser. So elevate our work in a fundraiser platform and see what funding we could bring in. And then from there, then that drew attention of the work that we were doing and we began writing grants. And then when those grants were successful and we grew the program, then we were able to partner with local nonprofits who wanted to assist us and our county offices and even the state level. So I think if you start just even very small, a $3,000 grant, a $5,000 grant, it helps you start somewhere and you start to build momentum. But eventually, yeah, as the program grows, you want to gain the attention of county organizations, the actual county agencies, and then eventually, your state kind of, for me, came last. It took me 20 years to get funding from a state level. So it's not what I set out for. It kind of rolled out naturally because of the work we were doing and the attention it had gotten. And I literally started with very tiny donations.
Mm-hmm. And something that I'll add, and then I'll pass it over to you, Jake, to bring us home, is that the Department of Labor has workforce development programs that are always looking for partners. And these partners don't think that a healthcare setting, right, would be someone that would be worthy of joining in on some of those grants and scholarships that connect survivors in your community to these education and employment opportunities. So a plug that I'll put out there, and you can reach out to me for more questions, is to really look at what those programs are in your community that are designed to help individuals with barriers to get education and employment, and then see if you can sign a memorandum of understanding with them to get services into your community. And so we can talk about that more, but I'll pass it over to you, Jake, to take us home. And thank you so much, Dr. Young.
Yeah, absolutely. There was another question in the chat. I don't know if we want to address that real quick, Jake.
Yeah, sure. Oh, yes, this one that just came in from Susan. Yeah, as a physician, how would you want to be approached by a DV-SAHT advocate to discuss being in a partnership with community organizations?
You know, I'm going to say I would start by offering education. Um, if you are an advocate in domestic violence, sexual abuse, human trafficking, there is a good possibility that the physicians you're reaching out to don't necessarily have a lot of knowledge about those areas. I can tell you that I came out of pediatric residency and I knew very little about child abuse and child sexual abuse. There is no requirement as a pediatrician to rotate through rotations like that. You have to learn cancer and diabetes. You have so many things to learn, even though more children will experience abuse than almost any of the other areas that I learned about. I didn't have much formal education on that. If you're an advocate in those areas, I think you should assume that you have a lot of expertise that would be valuable to a healthcare team to even just provide an education and say, here's what we do. And if you ever think that this is helpful or we could collaborate with you or you want to refer people to us, um, a physician should jump at that chance and should be open-minded to learn from you. That is how I would say I would start. I think even knowing all that I knew about child abuse as being a child abuse expert, human trafficking, exploitation, that was something I had to educate myself and go to conferences to learn about. I still didn't necessarily learn it in my fellowship training for child abuse. So offer your expertise because you have it.
Mm.
Alrighty, thanks so much. I think Dr. Chang brought up a good point as well to for connecting to your state primary care associations. That is a great way as well of connecting with just a large amount in general of health centers that are in your area, as those are the governing bodies or that kind of convene a state's health centers. So they might be an effective way to see who is interested within that health center body as well. Okay, and just to wrap up, if we can go to the next slide. Um, We have an evaluation poll. Oh, the slide before. We have an evaluation poll that I'm going to launch. If you can, please fill out this 5-question poll and let us know what you thought. And as you fill those out, we are going to move on to the next slide, please, and just get to some upcoming events that we are putting on. If you enjoyed this webinar, we do have a few coming up, including this one that we are partnering with the National Center for Equitable Care for Elders on. This one will be on March 11th at 10 Pacific, 1 Eastern, and it'll be 60 minutes. And you can use the QR code or the link in the chat as well, if you would like to participate in that one. And if we can go to the slide afterwards, we have another webinar coming up in March on the 19th. This will be at 11 Pacific or 2 p.m. Eastern, and it's in partnership with the Fenway Institute, and it's on prevention and safety planning, and addressing the intersections of HIV and intimate partner violence as well. And you can use the QR code as well to register or just find it on our website. And lastly, I just want to thank Dr. Young and Dr. Chang for the enriching conversation and Caroline as well for the enriching conversation that y'all had. It is really something special to hear about your work and how you are helping in these issues on this as we reach the end of Human Trafficking Prevention Month. And if you want to keep in contact, I believe Dr. Young had put her email in the chat, and we will send it out in a follow-up email to the webinar as well, along with the slides, a copy of the slides in both English and Spanish, and the recordings of each of these presentations, both in English and Spanish, will be sent out as well. And I want to thank all of y'all who registered and attended as well for supporting the work we do and for the work that you do in your everyday lives as well. And thank you.